Hello, this is Dr. Chris Ferrigno. Today we will be discussing the cranial nerves. So here are some of the goals for today's discussion. We certainly want to see these 12 cranial nerves. We want to learn their names and we want to learn their Roman numeral associated with them, and we're going to go in order from 1 to 12. We're going to look at what they do. What is their functional component? What exactly do they do? What are they responsible for? Are they purely sensory? Are they purely motor? Or are they mixed? We want to look to see what they innervate or where they come from. We want to see which nerves participate in parasympathetic innervation. We want to look at the autonomic ganglia associated with these cranial nerves. And we also want to look at the key reflexes associated with these nerves, including the afferent, or the sensory limb, or the input limb, and the efferent, or output limb of these reflexes. So let's take a step back and discuss what exactly a cranial nerve is. Well, just like that femoral nerve in the leg or the radial nerve in the arm, a cranial nerve is a peripheral nerve. They carry sensory and motor information, though, to the head and the neck, not to the limbs, like those other peripheral nerves. And they even carry some information to the trunk. They're called cranial nerves because they emerge from the cranium. So what kind of information do cranial nerves carry? Well, they carry just about all kinds of information. They carry general somatic afferents. In other words, they carry sensory information regarding touch, pain, temperature, vibration, but also proprioception. So they might carry information from a muscle to the central nervous system. They, of course, carry motor information. Not all of them, but many of them do. So these are carrying motor information to the skeletal muscles. This is called general somatic efferents. They have general visceral afferents, so they have sensory input from the viscera. Okay, this is particularly true with cranial nerve number 10 that you guys know, the vagus nerve, but we see others as well. And they have visceral efferents as well, like that vagus nerve carrying visceral information or motor visceral information to the to muscles, smooth muscle, heart muscle, and glandular muscles as well. Cranial nerves also carry information from the special senses, such as vision, hearing, balance, and taste. In the case of muscles and the nerves that serve those muscles, that are derived from the branchial arches embryologically, then we classify these nerves as branchial efferents. So approaching the cranial nerves is sometimes very overwhelming, and you should definitely try to incorporate some sort of mnemonic. Here are a couple mnemonics to help you. There's plenty more that you could find online, but these are ones that I sort of grew up with. So on the left, we have a mnemonic. Ooh, 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 to touch and feel very good velvet, such heaven. Now, the first letter of that mnemonic corresponds to the first letter of each cranial nerve. To the right, we have a mnemonic that gives you the generalized function. Some say marry money, but my brother says big brains matter more. And so the first letter of that mnemonic corresponds to the general function of each of those nerves. So in the case of the olfactory nerve, this is involved in smell, so this is special sensory. The S is just for sensory. Of course, in the case of the trigeminal nerve, which has both motor and sensory, the B relates to both. And here we see their Roman numeral for each of the nerves, starting with 1 and going down to 12. So let's take a look at each of these individually. During our discussion, we're going to run into 4 nerves, nerve 5, 7, 9, and 10. They're each derived from a branchial arch. And as you look at your embryology content, you guys will know exactly what I'm talking about when we discuss a branchial or pharyngeal arch. Just note that nerve number 5, or the trigeminal nerve, comes from branchial arch 1. Nerve number 7, or facial, comes from branchial arch 2. Nerve number 9, or glossopharyngeal, comes from nerve arch 3. And nerve 10, or the vagus, comes from branchial arch number 4. Now this slide will make much more sense after the brain development lectures, but you should know generally which nerves are associated with which brain structures. As you might be able to make out, most of the cranial nerves are associated with generally the brain stem. Here we have the midbrain, and color it in outlined in purple. And then we'll do the pons outlined in blue. And then we'll do the medulla outlined in green. So before we get into the brain stem, let's look at cranial nerve 1. It's associated with the telencephalon. Cranial nerve 2 is associated with the diencephalon. And then we have cranial nerves 3 and 4 associated with the midbrain. You notice I really say associated. They don't necessarily emerge from the midbrain, but they are associated with the midbrain. In other words, that they were derived from midbrain structure. The pons is cranial nerves number 5 through 8 is associated with the pons, and then cranial nerves 9 through 12 are associated with the medulla. I have a small way of breaking this up a little bit further to help me remember. Dancers may start a dance by saying 5, 6, 7, 8. And as you can see here, all those associated with the pons are 5, 6, 7, and 8. So here's another view, and we have the midbrain area, about right there. And then we have the pons, color that in green, outlining that in green. Here we have the pons. Again, this is an anterior view. And over here is a posterior view. So as you can see, most of the structures emerge from the brainstem somewhere, at least in the lateral or anterior side of the brainstem, with the exception of one, cranial nerve number 4, which is emerging out the posterior side of the brainstem. Let's stay to the anterior side, and here we have cranial nerve number 2, again, which is associated with the diencephalon. It's not emerging from the midbrain, but it's emerging out just above the midbrain. And then we have cranial nerve 3 and over here 4 emerging close to where the midbrain and the pons meet. And then we have cranial nerves 5, 6, 7, and 8 all coming out from the pons or at the pontomedullary junction. So where's that pontomedullary junction? Here is this pontomedullary junction. So you can see the 5 comes out laterally, and then 6 is now most medially, so we're going to kind of go in this direction to go to 6. So I'll just label this as 6, 7, and 8 from medial to lateral. And then when we go to the midbrain, when we go to the medulla, the number 9, 10, 11 all come out from a common root out of the medulla here. And then we have to go medially to get to number 12. For each of the cranial nerves, we'll mention where they exit the cranium. So in other words, they're found within the cranium, so they're found somewhere in here, coming off the brain or the brain stem, and they're going to have to go into the face or the neck. And so how they get there is through the small foramen. Here's a foramen, This might be a foramen. Here's a foramen, etc. And so we're going to look to see where they exit out where each nerve exits out of the skull. Cranial nerve number 1 is the olfactory nerve. The olfactory tract exits out of the forebrain. Remember, it comes from the telencephalon. Here is the olfactory tract. The tract kind of balloons out into what's called the olfactory bulb. And then the olfactory bulb on the inferior surface, so facing us, would have these little wispy hairs called the olfactory nerves, which descend down through the foramina of the cribriform plate. So imagine if we took this brain on the left, flipped it back over so it's resting in this cranial cavity. So the forebrain would be resting here in the anterior cranial fossa. And those olfactory nerves, here we see them going down through the foramina and the cribriform plate to enter into the nasal cavity, where they could pick up the chemicals in the sense that we are smelling. So here we can get a better appreciation of that. So again, I'll draw in what was effectively the proximal olfactory tract, going into the distal olfactory tract, ballooning into the olfactory bulb, and then sending off those individual olfactory nerves, which, by the way, are bipolar nerves because they're special sense. And they exit through these foramina in the cribriform plate of the ethmoid bone. Cranial nerve number 2 is the optic nerve, and as you might imagine, this is going to allow us to use the special sense of vision. It's like a great big one-way data cable. Okay, so here we see the optic nerve exiting the canal. Exiting the skull through the optic canal. And that's from within the skull, but we can look into the orbit here, and we can see that optic canal here as well. You can see a few openings within the orbit. Here we have a rounder opening, and then to the lateral side, we have a more fissure-like opening. We'll talk about that in a little bit. We actually have a couple fissures. The optic nerve connects the retina to the occipital lobe via a relay center called the lateral geniculate body in the thalamus. The optic nerve enters the skull, again at the optic canal. Please note that most of the other structures entering or exiting the orbit do so through that fissure that I mentioned called the superior orbital fissure. What's pretty interesting is that the optic nerve is actually visible during the eye examination using an ophthalmoscope. So here we see the optic disc. And so at this point during an eye exam, you're actually looking at real brain tissue without invasive measures. Cranial nerve number 3 is the oculomotor nerve. It's associated with the midbrain and emerges out of the junction of the midbrain and the pons. So we can see that right here and here. It exits the skull in the superior orbital fissure. So we saw that in the anterior eye before. But we're going to catch that nerve as it travels this way and then out that superior orbital fissure. So it's going essentially up underneath the anterior cranial fossa, but through the middle cranial fossa to exit out through that fissure. So here we get a good view of that superior orbital fissure. So this is medial, this is lateral. Here's that optic nerve coming out of the optic canal along with the ophthalmic artery. But within the superior orbital fissure, we have the oculomotor nerve here and here. It's just branched at this point. So it's exiting out both through the superior orbital fissure. But as you can see, we have other cranial nerves as well coming out. We have a portion of cranial nerve number 5. We have cranial nerve number 6. We have another small portion of cranial nerve number 5. And we have cranial nerve number 4. So what comes out of that superior orbital fissure? We have 3 4, part of 5, particularly 1. So we call that V1. We'll get to that in a minute. And we have 6. So we have 3, 4, 5, and 6, but only part of 5. So the oculomotor nerve is responsible for quite a few tasks. One, it innervates 4 of the 6 extraocular eye muscles. Let's take a look at those. It innervates the superior rectus muscle, the medial rectus, and the inferior rectus. Now, again, there's a superior and an inferior, and then if there's a medial, there's probably a lateral, and there is. That is not innervated by oculomotor nerve. But oculomotor nerve also innervates what's called the inferior oblique muscle. So here we have that middle rectus. Here we have the superior and inferior rectus muscles as well. And then this guy sweeping across here and grabbing the lateral portion of the eye is the inferior oblique muscle. It's actually coming off of the inferior medial orbit over here and wrapping all the way across. So as you might imagine, if the superior rectus contracts or shortens, it's going to pull the eye that way. So it's going to elevate the eye or help you to look up. The medial rectus will help you look in. The inferior rectus will help you look down or depress the eye. Then the inferior oblique is a little hard to appreciate, but if it contracts, it's going to pull that way. And so the eyeball will rotate out. Okay, that's called extorsion or external rotation. Now, depending on the orientation of the eye, if the eyeball is abducted or adducted or elevated or depressed, and then the inferior oblique acts on that eye, you might imagine that the action of the inferior oblique might be a little different, again, depending on the orientation of the eye at any particular time. Oculomotor nerve also helps to lift the upper eyelid with the levator palpebrae muscle. Another really big function of cranial nerve number 3 is parasympathetic innervation. So this is our first parasympathetic nerve from the cranial nerves. So what does it do? It helps to constrict the pupil. So it innervates the constrictor of the pupil, and it also helps to accommodate the lens. So both of these are used when we want to see something up close. And of course, constriction of the pupil happens when we go into brighter environments, especially if we've been in darker environments, so the pupil constricts. In other words, the pupil will get smaller to let less light into the eye. So as you might imagine, the extraocular eye dynamics is quite complex. What makes it complex, in addition to just having many muscles, is that the orbit is oriented slightly differently than the eyeball itself. So there's the orientation of the orbit, and so the axis, the long axis of the orbit, we'll put it in blue, we'll run right up the center, while the axis of the eyeball itself, when looking straight ahead, is facing that direction. So it's a little off. Thus, the superior rectus muscle, as we can see here with the red line, is able to pull. When it pulls, if everything else is able to relax and the superior rectus contracts, it's able to pull the eyeball up. Remember, this is a superior view, so it's going to contract and pull the eyeball up, but it's also going to pull the eyeball in a little bit as well. The medial rectus generally just has an inward pull. So if the medial rectus contracts, it's just going to make the eye go in. And similarly, we don't see this here because it's not innervated by cranial nerve 3. The lateral rectus would make the eye go straight out. Let's clear the screen and now talk about the inferior rectus. Well, as you might imagine, just like the superior rectus could roll the eye inward a little, I shouldn't say roll, should draw the eye inward a little bit, so does the inferior rectus. So not only does the inferior rectus bring the eye down, it can also bring the eye in just a little bit, just like that superior rectus brought the eye in. Again, this is because the eye orientation, the axis of the eye itself is different than the axis, or the alignment, I should say, of the orbit. Then comes the oblique muscles. So, as you might imagine, this inferior oblique, again, this is a superior view, so this dotted line represents, this bright blue dotted line represents the pull of the inferior oblique. So you can see it's originating from the medial orbit, and it has this oblique orientation, thus its name. It's oblique orientation. It's going to travel laterally. It's going to wrap up underneath the eyeball and catch on this lateral side. But you can see its orientation at this point. So when it contracts, it can extort the eye, or it's going to, when it contracts, it's going to roll the eye outward. Again, this is a rolling motion, so this might be difficult to see if someone extorts and you're looking at their eye, because it's just like a wheel, it's going to roll outward. It's not going to necessarily abduct, okay? But in addition to extorsion, it also allows the eye to look out and upward. Okay? So it'll roll the eye out, but it'll also have the eye abduct and then go upward as well. So here we see that action of the inferior oblique. So once again, that inferior oblique helps to extort the eye. So here we see the eye, the northern pole of the eye at 12, and we'll see that move over, and that's called extorsion. So if we were to look at the upper edge of the iris, it would rotate out, and that's called extorsion. So once again, the oculomotor nerve provides parasympathetic control to the intrinsic muscles of the eye, producing accommodation and pupillary constriction. So with accommodation, here we see a picture of the ciliary muscle, and it's a circular muscle going all the way around the eye. Note that there are suspensory ligaments attached to this muscle on one side, on the outer edge of those suspensory ligaments, and on the inside it's supporting the lens shown here in blue. So as you might imagine, when the ciliary muscle relaxes, its circumference gets smaller. When the circumference gets smaller, the suspensory ligaments become lax. So we see that over here. So the circumference of the ciliary muscle is smaller. The suspensory ligaments relax, which allows the lens to bulge. You might imagine when the suspensory ligament becomes taut or gets pulled outward, then that lens is now not going to be able to bulge. It's going to become flattened, right? So when you have relaxation of this ciliary muscle, okay, you get a globular lens. And when you have tautness of your ligaments, you have a flattening of the lens. When you have an increased lens curvature, this is called accommodation. So cranial nerve number 3, or the oculomotor nerve, also innervates the sphincter pupillary muscle. So in other words, it constricts the pupil. So just like with the ciliary muscle, which starts off as a large muscle when it's relaxed, as it contracts, the circumference of it and the diameter, of course, gets smaller. Well, the sphincter pupillary muscle is the same way. It's it's quite large when it's relaxed, and when it contracts, the diameter and the circumference of that circle or of that muscle gets smaller, thus constricting the pupil. And this is driven, again, by the cranial nerve number 3, parasympathetic fibers, which synapse in what's called the ciliary ganglia, located just behind the eye in the posterior orbit. So cranial nerve number 3 is going to come in. There's going to be a synapse of nerve fibers within this ciliary ganglion that are responsible for this lens accommodation and pupillary constriction. So let's move on and talk about cranial nerve number 4, which is the trochlear nerve. It's responsible for a single eye muscle, the superior oblique. The nerve is the only cranial nerve, as you may recall, that exits the brain stem posteriorly. So while we see it here anteriorly, remember it came out of the brain stem posteriorly. And as we can see here, the right cranial nerve actually originates from the left side of the body here, from the left side of the brainstem, I should say. And of course, vice versa with the left nerve exiting from the right side. It takes because of this crossing around the brainstem, it takes quite a long route, crossing the posterior midbrain before entering the contralateral superior orbital fissure. So again, it's got to go through the superior orbital fissure way over here. So because of this long route, it's prone to injury. Why? Well, number one, it can get tractioned. Okay, imagine that the brainstem goes that way, but the eye mechanism may go that way at some point, and we may get a tractioning injury where the nerve gets lesioned here, or maybe as it exits in this area. So once again, here we see that cranial nerve number 4, or the trochlear nerve, exiting out the posterior aspect of the brainstem near the midbrain pontine junction. So the superior oblique muscle arises from the posterior orbit, then loops through a pulley or trochlea in the medial socket, and then heads laterally and posterior. So let's take a look at this. Here we see the origin point on the posterior medial aspect of the orbit. The muscle goes through this pulley system and then traverses back posterior and lateral to attach to the upper lateral edge of the eye. So because of these attachment, when it contracts, it rotates the eyeball inward or in towards the eye. If we take a look over here at this 12 o'clock position, you'll note that the intorsion is when the eyeball rotates inward. With the contraction of the superior oblique, the eye is also going to go outward and then downward. So it's going to go down and out. So let's take a minute break from extraocular eye muscles to talk about the cavernous sinus, which is a network of thin-walled veins through which several cranial nerves traverse. Again, this is part of the dural venous sinus system within the cranium. And they're of great clinical importance because these nerves, as they travel through this venous network, can become involved if there's an infection in that area. So cranial nerve number 3, 4, parts of 5, and cranial nerve 6 all travel through these sinuses. Note that cranial nerve 2, here's cranial nerve 2, does not. As you can see here, here's the pituitary gland, which is sitting kind of in the middle of this network, but not necessarily perfectly within the network. These nerves, again, travel through these sinuses and can become affected if there is an infection in this area. Cranial nerve number 5 is the trigeminal nerve. As you can see here, it has 3 divisions: the ophthalmic division, or the ophthalmic nerve, the maxillary division, or the maxillary nerve, and the mandibular division, or the mandibular nerve. They also go by their abbreviations V1, V2, and V3. The trigeminal nerve has several very important functions. First, it provides sensory information to the head, including pain, temperature, touch, proprioception, and/or vibration from a number of areas. It also carries branchial efferent fibers, which provide motor innervation to the muscles that move the jaw, also known as the muscles of mastication, as well as other muscles derived from the first pharyngeal arch. So here we have our first muscle derived from the pharyngeal arch. In the middle cranial fossa, the sensory root of the trigeminal nerve expands into the trigeminal semilunar ganglion, which contains the cell bodies of sensory neurons in the trigeminal nerve and is analogous to the dorsal root ganglion. So here we see that semilunar or trigeminal ganglion. And remember, all 3 of these divisions are bringing sensory information in. So just as, let's say, our C5 nerve root carried sensory information from our lateral arm up, they went through that dorsal root ganglion, right? That the sensory information came up through the dorsal root ganglion to enter the spine. Well, similarly, sensory information travels up and into here where we have all those cell bodies located for all these sensory neurons before they end up getting transmitted further back into the pons area itself. So again, that semilunar or trigeminal ganglion is basically a dorsal root ganglion for all these sensory neurons. So here we see the very large trigeminal nerve exiting from the lateral pons, and soon it'll branch into 3 branches. V1, the first branch, or the ophthalmic branch, exits the skull through the superior orbital fissure. So if we take a look here, again, anteriorly here is that superior orbital fissure. V2, or the maxillary branch, will exit through the skull in the foramen rotundum and route to the maxilla. V3, or the mandibular branch, exits through the foramen ovale. So we have the superior orbital fissure, the rotundum, and the ovale for V1, 2, and 3. And here we have another view of that. So here we have that break in the skull, a longer break, that's the superior orbital fissure. And then here we have the rotundum and the ovale where V1, 2, and 3 are transmitting. So once again, a very large role of the trigeminal nerve is to serve as cutaneous innervation to the head. And here we see the distribution of V1 shown here in green, V2 shown in yellow or orange, and V3 shown in blue. So it's quite a very large distribution, especially in the face of this trigeminal nerve. One important function of the trigeminal nerve that I neglected to mention was the role that it has in sensation to the anterior 2/3 of the tongue. Now note, I didn't say taste. That's going to be served by the facial nerve in the anterior 2/3, but it does provide sensation via this mandibular branch that comes down to allow us to feel very discriminately with that anterior 2/3. Cranial nerve number 6 is the abducens nerve. So the abducens nerve comes out of this medial pontomedullary junction and traverses anteriorly to exit through the superior orbital fissure. So the abducens nerve carries GSE fibers, which provides motor innervation to just one extraocular eye muscle, the lateral rectus. So when this lateral rectus contracts, it pulls laterally on the eye and allows the eyeball to abduct. So here we see this person abducting. Cranial nerve number 7 is the facial nerve. Please note here, there is a whole separate lecture on the facial nerve given by Dr. Wilson. It's an excellent lecture. I highly recommend that you watch that after looking at this intro to the cranial nerves so that you can understand the complexity of this, both in its function and in its routing. So what does the facial nerve do? Well, again, it does a lot. As we saw in the trigeminal nerve, which serves sensation to the anterior two-thirds of the tongue, the facial nerve does taste to the anterior two-thirds of the tongue. It gives us general sensation over parts of the ear and behind the ear. That's not very important. But what is important, that it serves the muscles, I should say, of facial expression. So what is the muscles of facial expression all about? Well, these are all those muscles in our face that allow us to frown and smile and pucker and give signs of fear and give signs of elation and everything else. So this is very important for us as humans to have these signs of facial expression, and that's specifically served by the facial nerve. The facial nerve also serves parasympathetic functions. Specifically, it innervates 2 of the 3 saliva glands, the submandibular and sublingual gland. Interestingly, it passes through the parotid gland, but does not innervate that parotid gland. Rather, that's the job for cranial nerve number 9, which we'll see in a little bit. It also innervates the lacrimal gland. So what is the lacrimal gland? Well, lacrimal means tears. So it's going to innervate the gland that rests on top of the eye that helps to produce tears for the eye. So when we are in a parasympathetic mode, if you will, we can produce tears, and then we get kind of dry-eyed to keep our vision very clear when we are in a sympathetic mode. So our tears will dry up. The lacrimal gland will shut down and will be in a sympathetic mode. But under parasympathetic control, that's via the facial nerve into that lacrimal gland. So cranial nerve number 7, the facial nerve, exits the skull through the internal auditory meatus. Note that this is the general location of that meatus. On the left side, I'm going to draw a line that indicates where the petrous portion of the temporal bone is. So the petrous means rock, and so there's this very large, hard bone over here called the petrous portion of the temporal bone. And if you notice, all of the previous or the first 6 nerves exited the skull anterior to the petrous portion of the temporal bone. The remaining 6 nerves all exit the skull posterior to the petrous portion of the temporal bone. So we have 1 through 6 somewhere here, and then we have 7 through 12 posterior to that petrous portion. So here we see the facial nerve, at least its motor distribution out into the face to serve the muscles of facial expression. I'm drawing a dotted line showing you that this facial nerve is extensively intertwined within the parotid gland, but interestingly, like I said before, it does not innervate the parotid gland. So here are 5 peripheral branches of the facial nerve: the temporal branches, the zygomatic, the buccal, the mandibular, and cervical branches. Okay. So if we take the first letter of each of those, the zebra bit my cheek is a good way to remember those. So the zebra bit my cheek. So the temporal branches, again, go up into this temporal area. So we'll change the color here, we'll call this the temporal area. So the temporal branches will go up into that region. And then the zygomatic branches will head towards the zygomatic arch. So we see that kind of up, up here and here. And then the buccal branches will go towards a muscle called the buccinator. The mandibular branches will head a little further down into and along the mandible. And then the cervical branches, of course, will go down into the cervical spine up underneath the mandible. So cranial nerve number 8 is the vestibulocochlear nerve. Vestibulo meaning balance information, which will be coming from the semicircular canals, and the cochlea, which is going to be taking auditory information from the cochlea itself. So here we see cranial nerve number 8. It's quite large, and we see it running up against cranial nerve number 7. So it traveled together through this internal auditory meatus. It's the internal auditory meatus because where's the external auditory meatus? That's here. That's the ear canal itself. And so cranial nerve number 7 and cranial nerve number 8 are both transmitted via this internal auditory meatus. And if there's a problem within this meatus affecting one, it usually will affect both. So sometimes there's a condition called a schwannoma with the vestibulocochlear nerve, and that schwannoma would affect this nerve up in here. And that schwannoma might grow and compress on cranial nerve number 7 as well. So you might get some hearing disorders associated with, let's say, some taste problems or some motor problems to the face, things that the cranial nerve number 7 might be responsible for. And once again, we see that internal auditory meatus within the skull proper, right there, along with that facial nerve going in. And once again, this is posterior to the petrous portion or the petrous body of the temporal bone. So cranial nerve number 9 is the glossopharyngeal nerve, which also has a variety of functions. We just saw that the anterior 2/3 of the tongue is innervated by the facial nerve with regards to taste. So here's the anterior 2/3 of the tongue. We'll call that the facial nerve. Well, here the posterior 1/3 is the glossopharyngeal nerve. So that again, this is taste. And as you may recall, the facial nerve was taste. And then also, as you may recall, the general sensation was done by which nerve? Do you remember? It's cranial nerve number 5 for the anterior 2/3. But for the posterior 1/3, the glossopharyngeal nerve is going to do both sensation and taste. So that's what we see here. And it's also going to supply sensation to the pharynx as well. So we can see that back in this area. It's going to carry information, visceral information from the carotid bodies and the carotid sinuses, so information about blood pressure and pulse ox. It's going to be bringing branchial motor innervation to supply one muscle and one muscle only, the stylopharyngeus muscle. And I sort of remember that because the name glossopharyngeal supplies the stylopharyngeal. Yes, there should be an L in here, stylopharyngeal. And it also has visceral motor through the otic ganglion, which stimulates the parotid. So this is how that third salivary gland gets innervated, through the glossopharyngeal. And if you recall, the other two, the submandibular and sublingual glands, were innervated by the facial nerve. So we saw the facial nerve and that facial nerve and vestibulocochlear nerve exiting out of the internal auditory meatus, Here we see the next three nerves, 9, 10, and 11, all exiting out the jugular foramen. So there we see the jugular foramen just inferior and maybe a little bit anterior to the internal auditory meatus. So this brings us to cranial nerve 10, the vagus nerve, which we all know and love so much at this point. As you're well aware, the vagus nerve plays a very large role in the thoracic and abdominal viscera. But you may not know, well, you probably do, that the vagus nerve plays quite a large role in the neck as well. We saw the recurrent branch of the vagus nerve here on the left and then here on the right. And we learned when we were in the thorax that that was going to be extending up into the neck. So here we are. We're going to be touching on this right now. So certainly the vagus nerve gives off high branches. We don't even see these branches, but soon after it exits out of the skull, it's going to be giving high branches at the ear, both on the external auditory meatus and superficially, cutaneously, I should say. But it also gives branches here in the pharynx and other areas such as the larynx as well. Interestingly, the vagus nerve also gives us a little bit of taste. So we have taste receptors on our epiglottic or epiglottis and also in our pharynx as well. So we have a little bit of taste, but certainly primarily most of our taste comes through our tongue via the facial nerve and the glossopharyngeal nerve. And there is some branchial motor involvement with the vagus nerve, so it helps to supply the muscles of the pharynx, larynx, and tongue. So we're going to see this much more in when we get into the neck proper, but here we just see some of those branches, especially those going to the larynx. And we also see the recurrent laryngeal nerve looping up and around on the left and looping up and around on the right. Cranial nerve number 11, we all know, is the spinal accessory nerve. Of course, we saw this when we were in movement and mechanics. We saw this in the upper trap muscle. So we know that cranial nerve number 11 serves the trapezius, and here it is in its route. Remember, it came out of the jugular foramen. It's going to pass underneath sternocleidomastoid, and it's going to innervate this sternocleidomastoid. And it's going to continue on in this posterolateral or posteral inferior direction to innervate that trapezius muscle. So this is a motor, GSE motor supply only. So that brings us to cranial nerve number 12, the hypoglossal nerve. So as you might imagine from the name, hypoglossal means up underneath the tongue. And so this nerve is going to serve all the intrinsic muscles of the tongue and most of the extrinsic muscles of the tongue. So here we see a gentleman who has a deficit in his left hypoglossal nerve. The right hypoglossal nerve is relatively intact, thus you see the great muscle bulk that he has here. And so I'll draw another color. We have this side out. So when he protrudes his tongue, the muscles within this nerve that help to protrude the tongue are actually going to push the tongue this way. So his tongue is going to deviate to the affected side. So he has a left side damage, and so his tongue is going to deviate to the left. And just as a review, we have the nerves 7 and 8 exiting out here through the internal acoustic meatus, 9, 10, 11 exiting out here through the jugular foramen, and more inferior down towards the foramen magnum is the hypoglossal canal for cranial nerve number 12. So this is the last slide that we're going to spend any amount of time on. But we're going to work, it's a busy slide, but we're going to work from top to bottom. So first we have our cranial nerve reflexes. So remember, with any reflex, you need an afferent limb, or you need a nerve to be able to take information from the periphery back to the central nervous system. And then you need an efferent limb, or you need a nerve to take information or a motor response back from the central nervous system back to the peripheral areas. For the pupillary light reflex, so you shine a light in someone's eye, it goes to the retina. Cranial nerve number 2 is going to take information up to the central nervous system, and it's going to get briefly processed, and you will have a motor response via cranial nerve number 3. If you remember, it helps to innervate the dilator pupillary muscle. And so this cranial nerve number 3 is now going to give you a pupillary response. Okay, the jaw jerk reflex, you're going to tap on the lower mandible. You're going to put your, generally you put your thumb on their lower mandible, then you tap that thumb. Now you're going to have an afferent path up into the central nervous system via cranial nerve 5, specifically through that mandibular branch. And as you recall, all those muscles of mastication are innervated by cranial nerve 5 via that mandibular branch. So the efferent limb is going to come back down, and the nerve, cranial nerve V3, is going to innervate those muscles of mastication, and you'll get a response, most notably in the masseter muscle. So we have a full reflex arc there. Blink reflex, so you take a cotton swab and you rub the cornea, and the sensation on the cornea is innervated, as most sensation is in the face, by cranial nerve number 5. Now here we have the ophthalmic branch. It's going to go into the central nervous system, get briefly processed, and then you'll get a motor response back out of cranial nerve number 7, right, which helps control the orbicularis oculi muscle, muscles of facial expression. Okay, so you get a motor response out of cranial nerve number 7 via that orbicularis oculi muscle. Gag reflex, okay, you take a sterile Q-tip or a tongue depressor, and you swipe the posterolateral pharynx, and you get sensation through the glossopharyngeal nerve in the pharynx, and then you get a motor response through the vagus nerve to the muscles of the pharynx, and of the palate specifically, so you get some elevation of the soft palate in the back. Okay, we'll clear the slide there, and just to note here, we have a review or summary of the parasympathetic innervation, including the associated ganglia. So we have parasympathetic activity via cranial nerve number 3, and it's including that pupillary constriction that we just saw and the lens accommodation. We have secretion, glandular secretion from cranial nerve number 7, specifically the lacrimal gland and the submandibular and sublingual gland. Of course, we have the parotid gland secretion as well. And cranial nerve number 10, as you might imagine, has all kinds of parasympathetic activity. And here are those associated ganglion for that parasympathetic activity.